When we talk about bundle branch blocks, remember a bundle branch block is where one of the two bundles, either the right bundle of the right ventricle or the left bundle of the left ventricle, is for some reason being delayed. The conduction down that bundle is being delayed, and most of the time this is because of a structural abnormality or because of ischemia in that part of the heart. Remember that the way that we diagnose a bundle branch block, in order to say somebody has a bundle branch block, the first thing that we have to say is that their rhythm has to be supraventricular. If it's a ventricular rhythm, by definition, it's going to be a wide rhythm. In order to say somebody has a bundle branch block, the rhythm has to be supraventricular. So it has to initiate somewhere from the AV node up. Now, the second thing that we have to say about a bundle branch block is that while it's supraventricular, it also has to be wider than 120 milliseconds, or 0.12. So it's got to be wider than 3 little boxes, but it has to be supraventricular in nature. So it either has to be a junctional bundle branch block, or it's got to be some kind of atrial-driven bundle branch block. Now, when we talk about bundle branch blocks, the big thing that we're concerned about is which side the bundle branch block is on. Is it a blockage of the right bundle, or is it a blockage of the left bundle? And it's actually really, really easy to tell. What we're going to do is, when we've got our EKG, the first thing we do is we say, okay, yes, this is a supraventricular rhythm. Let's say I've got P waves, so I know that it's coming from the atria. The P waves correlate with every QRS, so I know that this is an atrial-driven rhythm. But it's wider than 0.12. So how do we know it's wider than 0.12? Remember, we said that if it's wider than 3 little boxes. Or the other thing is, we can actually look up at the top of our EKG where it says QRS duration and see if it says it's wider than 120 milliseconds. Now remember, in order to make the diagnosis of a bundle branch block, we only have to have the QRS wider than 120 milliseconds in one lead. So it doesn't have to be wider than 120 seconds in every lead. It's just got to be in at least one lead. So once we've done that, what we're going to do is we're actually going to look at V1. When we look at V1, what we're going to do is we're going to find the J point. Remember, the J point is where the QRS comes in contact with the ST segment. So we're going to go through the QRS complex and we're going to find right where it ends and the ST segment begins. That's the J point. Now what we're going to do is we're actually going to draw a line straight backwards. In other words, we're going to draw a line from right to left till we come to the next intersecting line. So as soon as we find a point where we intersect the QRS, where we find a deflection that intersects it, what we're going to do is we're going to take the area that's inside of that line and we're going to color it in. So for instance, when we look at the right bundle branch block that's all the way down in your left lower corner, what we would do is we would start at that J point and we would go all the way backwards until we intersected the QRS, and then we would color that in, and we would see that we now have a triangle that points up. If the triangle points up, that suggests to us that it is a right bundle branch block. In contrast, let's look at the left bundle branch block right next to it. So again, we go to V2, we find the J point, we draw a line straight back till we intersect the other side of the QRS complex there. We color it in and we see that the triangle points down. If the triangle points down, that is a left bundle branch block. So how in the world do I remember this? Well, the classic way that we always teach people is the turn signal theory. So once you've made your little triangle and you've colored it in, if the turn signal points up, or if the QRS points up, we said that's a right bundle branch. Well, when you're driving, if you flip your turn signal up, that would be telling people that you're getting ready to make a right turn. So up means a right bundle branch, and obviously if you're driving and you push your turn signal down, that would tell people that you're making a left turn. So if we've got a triangle that points down, we know that that's a left bundle branch block. Okay. Here's a good example of an EKG right here. Let's look at this one. When we go through and we look at it, we see that there's obviously QRS complexes that are wider than 0.12, wider than 1 second. So what we're going to do is we're going to go up and we're going to find V1. Once we found V1, we're going to color in again the QRS complex. We're going to start at the J point. We're going to work our way backwards to the first intersecting line. We're going to color that in, and when we color that in, lo and behold, what do we see? We see that the triangle points up. So this is a good example of a right bundle branch block. Now what about this one here? When we look at this EKG, again, obviously a wide QRS complex. We can clearly see P waves lots and lots of places, so we know that this is a supraventricular rhythm. This is not just V-tach. We know that this is actually a supraventricular rhythm, but it's wider than 0.12 seconds, so we know it's a bundle branch block. So we go up and we find V1 again. When we find V1, we find the J point. We draw a line straight from right to left till we intersect the QRS complex again. We color in the triangle, and lo and behold, it points down. So this is a left bundle branch block. Now, the reason why it's important to identify the right from the left, especially if it's new onset, is remember what we said about STEMIs. We said that there was 2 criteria that diagnosed a STEMI. We said the first one was if the patient has ST elevation in 2 or more contiguous leads. But remember, the second reason that's so important is because of the fact that if it's a left bundle branch block of new onset, that is your second proof of a STEMI. So anybody who has a new onset left bundle branch block has a STEMI until proven otherwise. Now, what about the patient who just lives with the left bundle branch? Why is that important? Well, it's also important to identify the left bundle branch block versus the right bundle branch block, because all left bundle branch blocks are going to have ST elevation. So if it's not a new onset left bundle branch block, if that patient has had a left bundle branch block for a long time, then when you see ST elevation on the EKG, it doesn't mean anything. We just assume that ST elevation is driven by the fact that the patient has that left bundle branch block. Okay, now we've talked about bundle branch blocks. The other thing that we need to understand is something called a fascicular block. Now, remember when we talked about the heart, we said that the conduction system was broken down into a right bundle and a left bundle. And remember the left bundle, we said it actually broke down into 2 fascicles. We had an anterior fascicle and we had a posterior fascicle. Well, a fascicular block is when we have a block of one of the 2 fascicles on the left side, when we either have a block of the anterior fascicle or when we have a block of the posterior fascicle. So when we talk about the posterior fascicle, remember we said the posterior fascicle is this really thick substance. It's ribbon-like in shape compared to the anterior fascicle. We said it was like thin, like a rope-like structure. And remember when we talked about the anterior fascicle, we said it had 1 blood supply. Remember when we talked about the posterior fascicle, it had 2 blood supplies. Okay. Now, when we talk about the way that we identify a fascicular block, we actually do that with something called the axis. So let's talk about axis for just a few minutes. The axis is actually something that people tend to make much more complicated than it really is. Axis is just a mathematical calculation of which direction most of the electricity is moving in the heart. And when we break down the axis, we actually break it down into one of 4 segments. Now, when you look at this diagram that's right below me, the one that shows the heart and the circle around it, this shows the electrical directions that the heart can take. So, for instance, if we had an axis that was 0 degrees, what that would tell us is the electricity is basically going straight left. If we had an axis that was positive 90 degrees, it would be going straight down. If it was 180 degrees, that would mean the electricity was basically going straight right. And if it was negative 90 degrees, that would tell us the electricity was basically going straight up. So when we talk about axis, we actually have a couple of ways that we can figure the axis. The easiest way to figure the axis is actually just to look on the EKG. And when you look on this EKG here, you see that there's, in the second column of words, you see something that says P-QRS-T. The QRS in the middle is actually what the axis is. And if you look across, you see 3 sets of numbers. The number in the middle corresponds to the QRS. So you see a first number there, that corresponds to the P-axis. You see another number there, and that corresponds to the QRS axis. So when we talk about, and finally the third number obviously correlates to the T-axis. When we talk about the axis, what we care about is the QRS axis. And you see, for instance, in this example, that this patient's axis is normal. It sits between 0 and 90 degrees. Okay, so that's how we figure out the axis. That's the easiest way, is to just look at the 12 lead. But when we break the axis down, we actually break the axis down into 4 sections. The first type of axis that we can actually have is a normal axis. And a normal axis is denoted on the diagram of the heart by the area that's in green. Anything from 0 degrees to positive 90 degrees is a normal axis. That's where we normally expect the electricity to be going. Now, if we have, if the axis moves more this way, then we would say that the patient had right axis deviation. And right axis deviation is defined as when the axis is anywhere from plus 90 to a plus 180. I'll say that again, a right axis is anywhere from plus 90 to plus 180. Now, when we look over at the other side is what we would call left axis deviation. And the way that we define left axis deviation is if the patient's axis is anywhere between 0 and -90. So basically anywhere from straight across left to up towards the face. Anytime we have that, that's left axis deviation. Now, while we're talking about left axis deviation, it's probably important to point out one little thing about left axis deviation. We actually have two kinds of left axis deviation. We have physiologic left axis deviation and pathologic. If the left axis deviation is anywhere between 0 and -30 degrees, I'll say that again, if the axis is anywhere between 0 and -30, we call that physiologic left axis deviation, and that doesn't mean anything. We still consider that to be normal. So really, we could say normal is really anywhere from 90 to 0 degrees and anywhere from 0 to 30 degrees. That's all normal. However, if the axis is anywhere between -30 and -90, then that is pathologic left axis deviation, and that is not normal. Okay, so we've talked about left axis deviation, we've talked about right axis deviation, and we've talked about normal axis deviation. The last type of axis deviation that we can actually have is something called ERAD, which is extreme right axis deviation. And the way we identify ERAD is the patient who sits between 180 and that 0 point. So if they sit between positive 180 and 0, that is extreme right axis deviation. And that patient, almost always, whenever you see ERAD, whenever you see extreme right axis deviation, that means that electricity is actually going completely the opposite way that it's supposed to. So instead of going from my right shoulder down towards my left leg, it means it's coming from my right leg basically going up towards my left shoulder. And there's really only one type of rhythm that works that way, and that's ventricular driven rhythms. So for instance, if we've got wide complex tachycardia and we're trying to figure out is it SVT or is it VTach, if the patient has ERAD, if the patient has extreme right axis deviation, if the axis is going this way, that is probably VTach. And that's another one of the values of axis, and we're going to talk about that more in just a little while. Okay, so let's look first at normal axis. Remember that we said normal axis is anywhere from 0 to 90 degrees, to plus 90 degrees. Now, sometimes we don't have the ability to access a 12 lead. Sometimes we don't have that quickly available to us. So another way that we can actually tell if somebody's got normal axis deviation, it's not 100% correct, but it's a good ballpark way, is we can actually look at leads 1, 2, 3. And if all 3 leads, if the vast majority of the QRS complex is positive, if the bulk of the QRS complex is positive, then that's probably a normal axis. And that's what we expect to see. So when you're looking at somebody's EKG, you expect to see that 2, 3, and AVF are positive complexes because that's a normal axis. Now, when we talk about left axis deviation, remember we said left axis deviation was broken down into pathological or physiological left axis. Remember we said if it was physiologic, that was anywhere from 0 to 30 degrees. And we said that we don't really care about that. That's normal. Some patients just have that for whatever reason, and that's fine. And if it's physiologic left axis, what we'll typically see is that 1 will be positive, 3 will be negative, and then lead 2 will usually be like somewhere in the middle. It'll be like about 50-50, half positive, half negative. In contrast, when we have pathologic left axis deviation, remember that's anywhere from -30 to -90, and between -30 and -90, what we will see on an EKG, if we don't have the ability to see the axis because we don't have a 12 lead, if we're just looking at leads 1, 2, and 3, what we'll typically see is that the QRS complex is positive in lead 1, but it's negative in lead 2 and negative in lead 3. So what does left axis deviation tell us? Well, one of the things that can cause left axis deviation is if we have left ventricular hypertrophy. If my left ventricle has gotten big because over time it's had to work really, really hard, then obviously there's more muscle over here, so there's going to be more electricity going this way to deal with all the muscle. So the bigger the left ventricle becomes, the more my axis starts to swing left. But the other thing that can actually cause left axis deviation is if we have an anterior hemiblock. So this brings us back to our fascicular blocks. When we talk about fascicular blocks, if the patient has an anterior fascicle block, that will actually cause a left axis deviation. Now, what about right axis deviation? Remember we said right axis deviation is when the patient's axis is somewhere between plus 90 and plus 180. So basically it's swinging down towards instead of swinging towards the left leg like what we would expect, it's swinging towards the right leg or even a little bit higher. With right axis deviation, probably the biggest cause of that would be right ventricular hypertrophy. So if the right ventricle has become hypertrophied, we would expect to see right axis deviation. And probably the most common place where you see this, you see right axis deviation all the time in people that have COPD, because if you've got COPD, a lot of times you get cor pulmonale, and with cor pulmonale you get that big huge right ventricle, and so we would see right ventricular hypertrophy and we would see a right axis. Now, the other thing that can cause right axis deviation is if we have a posterior hemiblock. So remember again, with the anterior hemiblock, we said we would see left axis deviation. With a left posterior fascicle block, with a left posterior hemiblock, we would see right axis deviation. And the way I always remember this, I don't know why, and I don't know if this will make any sense or not, but the way I always remember this is PRLA, like Public Relations Los Angeles. I don't know why I remember that, but PR, posterior right, LA, left axis deviation with an anterior hemiblock. So PR, posterior block, right axis deviation, LA, left axis deviation with an anterior block. I don't know why I remember that way. It may help you, it may totally confuse you, but it's just one of those things that's worked for me. Okay, now what would we expect to see if we didn't have access to a 12 lead, if we just had our 3 leads? Well, if we just have our 3 leads with right axis deviation, typically what we're going to see is that 1 is going to be negative, 2 is going to be either positive, or it's going to be equal, or it's going to be negative, so really 2 is of no help to us. But the big thing is that with lead 3, you're going to see that it's positive. So when we talk about right axis deviation, the real value there is looking at lead 1 and looking at lead 3. You see lead 1 is negative, you see lead 3 is positive. Okay, the last type of axis we said we could have was ERAD, or extreme right axis deviation. Remember we said right axis deviation is anything from 180 up to 270, or depending on the way the EKG is defined, it may actually be somewhere between negative 90 and 180. Some of them continue negative, some of them continue positive. Now, remember with extreme right axis deviation, the big thing we said is we would see a retrograde flow of electricity. That tells us that the electricity is going backwards, or in this case, it's going from left leg towards right shoulder. So obviously when we look at our 3 leads, when we look at 1, 2, and 3, what we're going to see with ERAD is all 3 of those leads are going to be predominantly negative. Our QRS complexes are going to be predominantly negative, and again, that suggests a ventricular arrhythmia. And this is the whole reason why usually one of the things we teach people when they're looking for PVCs is look to see if the PVCs are the exact opposite morphology of all the rest of the beats. Because if somebody's got normal axis deviation, usually each QRS is going to be predominantly positive in 1, 2, and 3. But yet your PVCs, because they're ventricularly generated, are usually going to have an axis that's extreme right axis, and so those patients, their PVCs will be the exact opposite morphology. They'll be predominantly negative in 1, 2, and 3. Okay, so let's get back to the whole fascicular block thing. When we talked about fascicular blocks, remember we said a fascicular block was when we had a blockage of either the anterior fascicle on the left side or the posterior fascicle on the left side. Remember that with the anterior fascicle, we expect to see that there's left axis deviation. With the posterior fascicle, we expect to see there's right axis deviation. Now, when we look at an EKG, one of the things that we're most concerned with, a fascicle block in and of itself is not that big a deal, but what we're really concerned about is when somebody has a bifascicular block. Well, what in the world is a bifascicular block? Well, a bifascicular block is when 2 of the 3 fascicles are blocked. So when we talk about the right side, remember that there really is only one fascicle, if you will. The right side is the right bundle. So the right bundle branch is basically the one fascicle for the right side. And then on the other side, on the left side, we have the anterior fascicle and the posterior fascicle. Well, if 2 of those 3 are blocked, we would call that a bifascicular block. And when we look here, this is a great example of a bifascicular block. Well, to be a bifascicular block, by definition, to be in the classic definition of a bifascicular block, the first thing that you have to have is you have to have a blockage of the right side. Well, if you have a blockage of the right side, what are we going to have? We are going to have a right bundle branch block. So the first thing we've got to look for is we've got to look at the EKG to ask ourselves, is there a bundle branch block? And when you look here, you see that there are leads where the QRS complex is wider than 0.12 or wider than 120 milliseconds. So we know that this patient has a bundle branch block. We know that it's supraventricular in origin. We can see P waves. So we know that this is truly a bundle branch block. So what do? We go back up to V1 and we do our little turn signal thing. So we go back to V1, we take a line from the J point back to where we intersect the QRS, and then we color in the triangle, and sure enough, here on this EKG, we see that the triangle points up. So that would tell us that this patient has a right bundle branch block. So then the question becomes, does this patient have a fascicular block as well? If the patient has a fascicular block, then that is a bifascicular block, and that is very concerning. That means that 2 of the 3 electrical conduction systems for their heart have been blocked. So when we look here, we see that 1 is positive, 2 is predominantly negative, and 3 is predominantly negative. So when we look, remember that if 1 is positive, that tells us that electricity is moving this way, because remember, this is where lead 1 is. So if electricity is moving this way, what does that tell us? That tells us that it is moving, that it is probably moving in a left axis, because it's negative in the other 2 leads. It's negative in 2 and it's negative in 3, so it can't be a normal axis because it's moving away from that area. It's moving away from our lower leads, so that would tell us that this patient also has a left axis deviation. So when we look at this EKG here, when we take all that and put it together, and I know it's a bunch, but when we take it and put it together, we've definitely got a right bundle branch block, so we've got a fascicular block. And then when we look, we also see this patient also has left axis deviation, so we can also say that this patient also has a anterior hemiblock as well. So this patient's got an anterior hemiblock and they've got a right bundle branch block. This patient has a bifascicular block. So this patient has lost 2 of the 3 conduction systems. Now you're probably looking at this and you're going like, why in the world do I care about this? Well, there's several reasons for us to care about this, and probably here's the number 1 reason to care about it. Because most of your ventricular antiarrhythmics, and the one that I'll pick on here for sure is lidocaine, those drugs are absolutely contraindicated for anybody who has an intraventricular block. So if this patient was having PVCs and you went to reach for the lidocaine, you would be giving a lidocaine to a patient who, right on the manufacturer's recommendations, says do not give this drug to anybody who's got an intraventricular block. So lidocaine would be absolutely contraindicated for this patient. Okay. Now let's talk about angina for just a few minutes. When we talk about angina, remember that angina is broken down into a couple of different types. The first type of angina that we've already talked about is stable angina. Remember, stable angina by definition was the angina that's very, very predictable. It's the patient who has sudden onset chest pain when they do certain things. They know exactly what the things are that trigger it, and they also know that if they do certain things, that makes the angina go away. Remember that the first time that any patient presents with angina, by definition, the first presentation, we typically say that that's stable angina, and that kind of becomes the baseline. When we talk about unstable angina, remember, unstable angina is the patient who has a change in symptomology. Remember that change in symptomology may be that it takes less work for them to get anginal symptoms, or it may be that it takes a lot more stuff to get rid of the anginal symptoms. When we talk about unstable angina in the setting of an acute coronary syndrome, remember we said that the classic thing we would see with unstable angina is the patient has chest pain, that a story that suggests they've got an acute coronary syndrome, but when we put them on the EKG, we either see diffuse or nonspecific EKG changes, or the EKG changes are transient, they come and go, or we see that the patient, in addition, we see that the patient does not have a change in their cardiac markers. We see that their troponin and all that stuff does not go up. Okay, the other way that we break down angina is based on, the other ways that we can break down angina are based on various other things. One of the things that you'll hear people talk about is something called variant angina. When we talk about variant angina, remember, variant angina is the patient that has spontaneous episodes of angina that are not related to work. So, for example, patients that have variant angina, they may have a group of symptoms like every day at 10 o'clock in the morning they have angina and they have to pop a nitro. It doesn't matter what they're doing. It doesn't matter whether they're sitting in the bathtub or whether they're mowing the lawn. It happens every day at 10 o'clock. That's a classic example of variant angina. It's usually related to their circadian rhythm, so it's usually like at a specific time of the day, and it's usually relieved by nitro. The other type of angina that we can have is we can actually have silent angina. Silent angina is when we have objective evidence of ischemia. So for instance, we may have those transient EKG changes, but the patient doesn't have the classic anginal type chest pain. So it may be the patient who just complains of nausea and feeling really, really weak, or maybe the patient who just suddenly becomes dizzy. Those are classic examples of silent angina. But the big thing is we have to be able to relate their symptoms back to dysfunction by their heart. The other angina that's not on here that probably should be is Prinzmetal's. Remember that Prinzmetal's angina is actually caused by spasms of coronary arteries, and a lot of times this actually responds really, really well to nitro. We can see Prinzmetal's angina with a lot of our drugs that we use, or a lot of drugs that people use that they shouldn't use. You see a lot of Prinzmetal's angina with things like cocaine and things like that. And finally, the last type of angina is mixed angina. When we talk about mixed angina, remember that that's when we have any combination of various types of angina. So for example, a patient may have variant angina, meaning that they have angina every morning at say 10 o'clock in the morning, but all of a sudden it starts to change. All of a sudden they start having it at 2 in the afternoon as well. Well, by definition, that's unstable angina as well, so we would call that mixed angina because it's got elements of both variant angina and it's also got elements of unstable angina. Okay, when we talk about treating AMIs and unstable angina, let's talk about the actual treatment for the various conditions. Well, remember the first thing, the big tenet that we've used for years and years and years is preload reduction. And the whole idea behind preload reduction is, remember when we talked about that coronary perfusion pressure? We said coronary perfusion pressure was the diastolic blood pressure minus the pressure in the ventricle. The more pressure there was in the ventricle, the more wall tension there was, the harder it was to drive blood into the heart. Well, when we're using things like nitrates and morphine, that's the whole purpose of those drugs, is to decrease the ventricular wall tension. And so when we talk about nitrates, remember that nitrates, the big thing that they do is they cause venous dilation. Now, the higher we get with nitrates, the higher up we go. Usually when we start getting above doses of, like, say, around 80 mics per minute, we actually start getting more and more afterload reduction as well. But at the doses we usually use with acute coronary syndromes, like doses less than 80 mics, usually the big thing that we're getting out of it is preload reduction. Now, a lot of people like to say that nitrates actually will cause coronary artery dilation, and that's absolutely positively a true statement in a 2-year-old. If you've got nice, healthy coronary arteries that haven't had years and years of McDonald's in them, then nitrates probably will do a little bit to increase your coronary arteries. But when you actually look at the evidence, in adults, typically we don't see that nitrates really do a significant amount to vasodilate the coronary arteries because your coronary arteries are full of crap. They're full of this very fibrotic stuff, and so we really don't see that effect. The big thing we get from nitrates, again, is the preload reduction. Now, when we give nitrates, there's a couple of different ways we can give them. Obviously, the first way we can give it is we can give it as a tablet. When we give it sublingual, we get almost 100% absorption of nitro, so it works very, very quickly, works very, very efficiently. We avoid that whole first pass metabolism through the liver, so they're getting almost the whole dose. But the limiting factor is the fact that we can't really titrate it. Once you've given somebody a tablet of nitro, you've given them 400 mics, and you're stuck with whatever comes out of that 400 mics, good or bad. When we talk about another way to give nitrates, we can also give it in the form of a paste. And we use paste a lot for people to control like unstable angina and stuff like that. But nitro paste is not a good choice for emergency medicine. It's a very poor choice for emergency medicine. And the reason why it's such a poor choice is because by definition, when somebody's having an acute coronary syndrome, as they start to get sicker and sicker, we see changes in their vasculature. We see changes in their systemic vascular resistance. And depending on how much blood flow comes in contact with the outer skin depends on how much nitrates you get. So it's very unreliable to give somebody nitro by paste when they're having an acute coronary syndrome. Instead, the better thing to do for those patients is to give them sublingual nitro, or even better still, to give them IV nitro. Remember, when we give IV nitro, we typically start at doses of like 5 to 10 mics a minute, and we can go as high as 200, or some will even say 400 mics of nitro. The big thing to remember there is that we have the ability to titrate it very quickly. Nitrates work very, very fast when we're giving them IV, so we get our effects very, very quickly. And also, if we kind of overshoot, it's also pretty quick that we can get rid of the nitrates by titrating down. So definitely titrating nitro by IV is probably the best, most efficient way to treat the patient who's having an acute coronary syndrome when we're using nitrates. Now, when we talk about morphine, remember that morphine's big advantage is that it's a narcotic, but the secondary advantage for acute MIs and for unstable angina is the fact that morphine also causes a histamine release. Remember that when you give somebody morphine, you get a pretty significant histamine release, and when we know that when we release histamine into the blood, that causes vasodilation and it causes an increase in capillary permeability, so we have the ability to park some fluid, so we also have preload reduction. Now, when we talk about giving morphine, there was this article that came out a couple years ago about morphine that made a lot of people think morphine was of the devil. This article said that there was a study that was done. It was a retrospective study that said that when we gave morphine to patients who were having MIs, it increased mortality. Well, if you actually read that study was actually something called a feeder study, and the whole purpose of that study was to get funding to do further research. But doing what we often do in medicine, we actually didn't do the research, we just read the headline and made a snap judgment. That study was a retrospective study that looked at patients who had morphine as part of their MI care compared to patients who didn't have morphine. And lo and behold, the patients who had morphine died at a higher rate than the people that didn't. There was nothing there to compare whether the morphine was the cause of death or not. There was absolutely nothing there. In fact, it would not come as a shock to me that the people that got morphine probably had higher mortality, because people that are having an acute coronary syndrome that require morphine are usually more refractory to pain because they're having a much worse MI. So lo and behold, it's not surprising that we would see higher mortality in those patients. So morphine has still been a staple of care for MIs. There hasn't been any research to show it's a bad thing. There hasn't been a lot of research to show that it really makes a difference, but there hasn't been any research to show it's a bad thing either. So it's still definitely a staple of care of management and treatment of the patient who's having an acute coronary syndrome. Okay, now when we talk about management and treatment of AMIs or unstable angina, if we go back and we look through all the literature that makes up our current ACLS guidelines, if we were to only pull out the pieces that are based on the strongest, most powerful literature, then actually there's very few things that we could actually say absolutely positively make a difference. One of the things that we know absolutely positively does make a difference for patients who are having MIs is beta blockers. We've demonstrated time and time again that when patients are given beta blockade, it decreases their heart rate, it decreases contraction, and because of that, it decreases oxygen demand. So it's almost cardioprotective. It almost keeps the muscle from overexerting itself. So we absolutely positively know that beta blockers play a major role in the management of AMI treatment and should be one of our first-line therapies. Now, what about the discussion about calcium channel blockers? There's also been some studies that have looked at calcium channel blockers, and they found some similar effects, but not as well as with the beta blockers. So as things stand now, kind of the general guideline is that everybody who's having an MI who doesn't have a contraindication probably should get beta blockers, and those patients who have a contraindication to beta blockers but do not have a contraindication to calcium channel blockers may be given calcium channel blockers instead. But beta blockers are definitely the therapy of choice. We would much prefer to use beta blockers to calcium channel blockers if we have our choice. Now, when we talk about the actual clot prevention and busting, remember that there's three things that we use from the coagulation perspective. The first thing that we use is aspirin and G2B3A inhibitors. And going back to our discussion of ACLS, remember we said that if there was a couple, if we looked at the things that had really, really strong research, we would actually narrow down to a couple things. Well, on that list of our few things that absolutely positively make a difference right next to beta blockers would be aspirin. We know that aspirin makes a major, major difference in the management of acute coronary syndromes. It's really, really important that patients get aspirin on board. Now, when we talk about aspirin, remember that the way that aspirin works is it inhibits platelets from aggregating together, and if platelets don't aggregate together, they don't become active, and if they don't become active, then we don't start to form clots. Remember that aspirin is going to do nothing to break up clots that already exist. All it does is it helps to prevent platelets from aggregating and making more clots. Now, in line with aspirin, the other drugs that we use are our G2B3A inhibitors, and so good examples of our G2B3A inhibitors would be things like Integralin, Aggrastat, and ReoPro, and remember that they work basically the same way that aspirin does. They prevent that platelet aggregation. Now, when we talk about the clots themselves, the way that we treat the clots themselves, first off, is with heparin or low molecular weight heparin in the form of a drug like Lovenox. Remember that the way those drugs work, they inactivate thrombin and several other clotting factors. But again, remember that heparin and low molecular weight heparin are going to do nothing to clots that already exist. All they do is prevent existing clots from getting worse. Finally, the last clot drug that we use is the actual clot buster, which is a fibrinolytic. Remember, the way that fibrinolytics work is by various mechanisms, but what they all do is essentially convert plasminogen to plasmin, and plasmin is what breaks up fibrin. It's what breaks fibrin into fibrin degradation products. So fibrinolytics are the only one of these three classes of drugs that actually break down clots that already exist. Okay, in addition to our treatment with the clot busting stuff, there's some other things that need to be done in the first 24 hours. One of the other things that's very important in the first 24 hours is that any patient who doesn't have a contraindication needs to be put on an ACE inhibitor. Remember, the ACE inhibitors inhibit angiotensin from converting, and because of that, they inhibit angiotensin converting enzyme from allowing angiotensin 1 to become angiotensin 2. Angiotensin 2 is a very profound vasodilator or vasoconstrictor, and so when we put somebody on ACE inhibitors, what we're doing is we're decreasing their afterload. We're decreasing the workload that heart has to pump against. We have a decrease in SVR, and the other thing that it does is it inhibits sodium retention, so it prevents them from getting a buildup of sodium and thus a buildup of fluid like we classically see with CHF. Now, one other thing that we probably need to do within the first 24 hours is we also probably need to start the patient on Plavix. Remember that the way that Plavix works, it inhibits fibrinogen from binding, and thus it limits platelet aggregation. So those are some of the other drugs that need to be done within the first 24 hours for patients who are having an MI. Okay, so let's go back and let's talk about fibrinolytics for just a second. Remember, we said fibrinolytics, the big thing that they do for us is they actually allow us to break down clots that already exist. When we talk about fibrinolytics, the first thing you need to know is what the indication is in the setting of an acute coronary syndrome, and the only acute coronary syndrome that we treat with fibrinolytics is a STEMI. I'll say that again, the only acute coronary syndrome that we treat with a fibrinolytic is a STEMI. We don't give fibrinolytics to patients that are non-STEMIs. We don't give fibrinolytics to patients that are unstable angina. Now, when we talk about fibrinolytics, remember that there's several big complications. The first one, obviously, is that the patient can bleed. We know that the patient can specifically bleed in their head. We know that patients can have dysrhythmias as they reperfuse. We can see things like cardiac tamponade, and we can even see things like pulmonary edema. For the exams, the big thing you need to know is what the contraindications for fibrinolytics are. And we break our contraindications down into relative and absolute. So first, talking about our relative contraindications. One of our relative contraindications is hypertension. Any patient who's got hypertension, we need to think about whether or not we want to give them fibrinolytics. Now, that doesn't mean that if you've got hypertension, you don't get fibrinolytics. That doesn't mean that at all. It just means that we need to think about it. And specifically, what we're concerned about when we talk about hypertension is we're talking about malignant hypertension. So we're talking about people that have like a diastolic blood pressure over 110. For those patients, we're really concerned about giving them fibrinolytics because there's a high likelihood that they could develop a cerebral hemorrhage. Now, what do you do when you've got a patient who's having an active STEMI? You have the ability to give the fibrinolytics, but the patient is really, really hypertensive. Well, you control the blood pressure. If you can put that patient onto a beta blocker, a calcium channel blocker, or even onto a vasodilator and get their blood pressure down to an acceptable level, then you absolutely positively can go ahead with the fibrinolytic, assuming no other contraindications. Some other relative contraindications would be any history of recent trauma or if the patient is pregnant. Now, when we talk about our absolute contraindications, the things that absolutely contraindicate fibrinolytics are things like active internal bleeding, if the patient's got an aortic dissection, if the patient's got an intracranial neoplasm, and there's two big things you need to know about strokes. When we talk about strokes and fibrinolytics, here's the rules, and these are important. The first rule is if the patient has ever in their life had a hemorrhagic stroke, then that is an absolute contraindication to fibrinolytics. I'll say it again. If the patient has ever in their life had a hemorrhagic stroke, that's an absolute contraindication to fibrinolytics. Now, if the patient has had an ischemic stroke, those patients can have fibrinolytics if it's been at least 1 year. If the patient has had at least 1 year since their ischemic stroke, then that patient is a candidate for fibrinolytics and we can give the fibrinolytics. Okay, while we're talking about fibrinolytics, let's talk about the other alternative that's out there, which is PTCA. When we talk about PTCA, or when we talk about actually doing a cath on a patient, we need to look at what the evidence says. When we talk about breaking down MIs, remember we broke them down into unstable angina, we broke them down into non-STEMIs and STEMIs. Well, that breakdown, initially when it was very first thought of, the idea was that the patient who is having unstable angina, we would send that patient off to a cardiac unit, and then we would go back and cath that patient at some point that was convenient. For the patient who was having a non-STEMI, that patient would go straight to the cath lab, and that patient would be emergently treated in the cath lab. Finally, the patient who had a STEMI, the patient who had ST segment elevation MI, the big thought for those patients is that what we were going to do for them was we were going to give them the fibrinolytics. Well, there was a couple of studies that were done in the early in the 21st century, probably somewhere around like 2003, 2004, that actually looked at morbidity and mortality for patients who had a STEMI that was treated with PTCA versus a STEMI that was treated with fibrinolytics. And they actually found that if you could give fibrinolytics within 30 minutes, or you could do a PTCA and you could cath that patient within 90 minutes, there was equal mortality. So they actually found that it was equal mortality, and there was a lot of thought process there that, well, if we do a PTCA, that's a lot safer because of the fact that we're not giving the patient a systemic bolus of fibrinolytics. And so we've seen this huge change in practice for management of STEMIs. Now in most places, the big focus for STEMIs is on taking them straight to the cath lab and only giving the fibrinolytics if the patient cannot meet the 90-minute window for PTCA. So, what do we do if we're actually taking care of somebody who's had a PTCA or somebody who's getting a PTCA? Well, when we're talking about angina, remember that we're going to treat our angina the same way. If the patient's having chest pain, then we're going to give that patient nitrates. We're going to give the patient beta blockers. If there's not any contraindications, we're going to give the patient aspirin, and we're going to give them morphine. So it's that whole classic MONA kind of thing with the addition of the beta blockers. Now, when we talk about clotting, typically what we're going to do is any patient who's having PTCA is also going to go on a G2B3A inhibitor. And in most institutions and most places in the country, they'll start the G2B3A inhibitor as soon as they identify the patient's having an MI, and they'll continue that G2B3A inhibitor right through their cath. Now, heparin is something else that we can give these patients, but this isn't as widely agreed upon as the G2B3A inhibitors. In some institutions, they'll go ahead and start the heparin right off the bat, and then they'll stop it when they do the cath. Other places say, no, don't give the heparin until after the cath is over. So heparin is very much localized as to whether or not we use that before, during, or after the cath. Now, what about the patient who's already been cathed? Well, obviously, if the patient's been cathed already and you're taking care of them, the big thing that we're worried about in the first 24 hours is the potential that their stent is going to reocclude. So we want to make sure that we're watching their EKG and make sure that we're watching the right leads. We want to look at the leads specifically that were cathed. So, for instance, if you've got a patient who just had a cath of their LAD, but your EKG is set up to look at leads 1, 2, and 3, well, if that patient starts to reocclude, the only way you're going to know it is if the patient starts to complain of symptoms again. So it's much better to set your EKG up so that we're at least monitoring some of the leads that are actually looking at the part of the heart that's been cathed. The other thing that we want to do is if the patient has still got a sheath in place, we want to maintain it. In the transport setting, the best way to maintain it is actually to transduce it just like any other central line or arterial line, depending on whether it's right or left cath. And the big thing we want to do for those patients is watch to make sure that there's not a occult bleeding around that sheath. If you remember from trauma lectures you've had in the past, remember that when we talk about the thigh, somebody can lose as much as 1,500 cc's of blood in their thigh before it becomes clinically evident. If you've got a sheath in place and that sheath is leaking, needless to say, we could lose lots and lots of blood in that leg before we ever recognize it if we weren't watching to make sure that sheath was still in the vessel and was working appropriately. Now, the other thing is if the sheath is in place, we want to make sure that the vessel that's distal to the sheath is still patent. So we want to make sure we've got good distal pulses. Again, in the transport setting, one of the things we can do to make that a little bit easier for us is to put a pulse ox down on their toe, whichever foot is cathed. And if the sheath has been removed, remember there's two big things we want to know. The first thing we want to know is if the sheath has been removed, how long do we have to maintain direct pressure? And it very much depends on the type of sheath. So this is something that the cath lab nurses should be able to tell you. Some of the sheaths you have to hold direct pressure for 30 minutes, some it's less, some it's more. So we want to know with this particular sheath, how long do we need to hold direct pressure on the leg? And the second thing is if the sheath has been removed, we also want to know how long does the patient have to lay flat or less than 30 degrees. If the patient has to lay flat or less than 30 degrees for an extended period of time, then we need to know about that. And again, it very much depends on the sheath. Some of the older sheaths, those patients had to lay flat for like 4 hours. Some of the newer sheaths, those patients can actually sit up in as short as like an hour or two. So you definitely want to ask those questions of the cath lab nurses so that you know exactly how to deal with the sheath removal.
Okay, let's take a break here, and when we come back, then we'll talk about putting all this into practice.
I'd come for you, no one but